Angel Heart or the Skeleton Key. I don't remember exactly.
Angel Heart. Yeah, with the skeleton key at 12:30. Okay, Angel Heart. So where do you want to start?
I think an interesting place to start, probably the whole point of the movie, with the whole kind of soul switching. I was thinking of before knowing what was going to happen.
In who?
In Angel. I guess technically Johnny Angel's twin.
Okay. What leads you to believe that this movie is about DID?
Well, so I did think it was DID, just they added the magical nature to it, so they kind of explained it in another way, but I think it could be a good representation of that.
Okay. So then I guess the kind of tangent question would be, what is DID? Right? Dissociative identity disorder. What is this?
So this is when people typically who have had some type of trauma in their childhood, sexual, physical, their mind develops a different way of coping with that by, I don't want to say the word creating, because that means like it's fabricated, but they develop different personalities or sides of themselves to deal with that. So for example, one of the others or personalities can be the protector. One of them can be, a regressed version of themselves that's more childlike, etc. So they depersonalize themselves by having another personality.
I think that the terminology I would like to use is that they enter into an altered state of consciousness. And again, there are various forms of this, various degrees of this, and in its most severe form, they have their conscious awareness taken over by a distinct personality state, allowing that personality to experience that trauma and therefore sparing themselves from processing and registering the memory. And while this might actually be life-saving during the trauma itself, certainly it could become a symptom of a problem and mental disorder thereafter, where that altered state, referred to as an alter, takes over their conscious awareness even when there is no imminent trauma. And it can be cued, but it could also be uncued. And we think that's happening with the main character here. What scene would be most indicative or supportive of that?
I think maybe the ending when they just explain when the Marcus' father is talking to him, and he's kind of like having flashbacks of seeing he's done these things to these people, like suicides or murders.
And what I think is most interesting about that is that, on the surface, this looks like dissociative amnesia, right? Where the individual in question simply doesn't remember having committed those murders, and in a twist that is the movie plot, basically is hired to search for himself. But knowing what we know, and certainly watching this movie through, or viewing it through a psychiatrist's lens, we know that the reason for that amnesia, that forgetfulness, is that there was an altered state, even though that's not necessarily explicit in the movie script per se. And therefore, again, and this is a clinical pearl that can show up on your shelf exam, that the single best diagnosis is in fact DID. DID does incorporate aspects of dissociative amnesia. The clinician would not diagnose both. Dissociative amnesia is part of DID for that very reason, because the memories are simply not encoded, they're not registered. At least not by left brain. Anything else going on in this character beyond the original diagnosis of dissociative identity disorder?
I don't know if this would necessarily be a diagnosis, but he seems to be very fixated on tracking down Johnny Favorite. Like, even, for example, like somewhere towards the middle of the movie, even when he wanted to quit, what's his name, Cypher offered him like a bunch of money, and he was like, oh, okay, like I'll keep going, even though it was already shown to provide him a lot of like psychological distress. So it was just interesting to me that he kept going, and maybe he was internally fixated on the whole investigation for multiple different reasons. So, yeah.
And again, we can certainly use the clinical terms of obsessed or even preoccupied, and because it does not appear that either OCD, anorexia nervosa, or bulimia nervosa are the single best diagnosis in this character, or perhaps not even a co-occurring diagnosis, we could actually use those two terms interchangeably in this case. Right? But fixated would be an actual term as well, albeit not necessarily one related to the mental status exam. When we say fixated, we're probably more talking about a defense mechanism regarding one's development or personality development. That is, they're fixated at a psychosocial or psychosexual stage of personality development, which may be going on here as well. We just don't know enough about the main character's developmental history to actually say that, though. Might there be another reason for this observation? That he does seem to be obsessed / preoccupied, of finding the character that he was hired to find.
Can't we just say that he's motivated by money? Right, like he tried to get out of it until he was offered more money. Is that like, it's like, I really like coming to the hospital, but like doesn't mean I'm fixated on coming to the hospital. This is like, my secondary gain is getting an education.
I would put that at the top. Certainly, money can be an absolute primary motivator here. Absolutely. Is there any evidence in this movie, any scenes to suggest that it's beyond that? Where maybe he would have gotten his money anyway, but he seems to push forward nonetheless. So the answer is no. That jumps to the top of our list. If there's some scenes that seem to be incongruent, we have to consider there might be other things going on.
I mean, also like when he's in New Orleans and everything that happened there, when he found like multiple people murdered, and then he had sex with a 17-year-old, and then he continued like the whole time. He could have stopped multiple points there. He already had the money at that point. It didn't seem worth it, but he kept going.
So he did have his full allotment at that point? So maybe there was another motivator then, if that is the case. Any other thoughts? That's a hint, by the way, the way I phrased the question.
So no, he didn't have the whole allotment then.
Well, I mean, assuming that he did, hypothetically, just so we can talk about this particular topic. I mean, we mentioned that he's not registering memories, at least, and I kind of gave it away, at least not in his left brain, but he is in his right brain. That is, I mean, individuals who experience the trauma are cued with circumstances, people, places, things that will remind them of the trauma, even though they may discreetly tell you, I've never experienced trauma, doc, which is a common part of their history, even though they may have established post-traumatic stress disorder, denying they ever had a trauma. And that's because they don't remember it, but it still happened. Well, if it happened and they don't remember it, why is it that they're triggered? Well, it's because it is processed, just not by left brain. So they do have these artifacts of memory. And maybe this character does as well. And maybe that's what's motivating behavior, because right brain can motivate behavior just as much as left brain. And that might be actually what we're actually seeing here. For purposes of DID, right brain, left brain, how can we reintegrate these two hemispheres so that he does actually remember? So that people struggling with this illness actually do remember and then process the trauma in a more effective or adaptive way, and maybe have a resolution of symptoms as a result. I'll give you a hint. There are no FDA-approved medications that will reintegrate left and right brain functioning.
Can you discuss the differences between right and left brain functioning?
Yeah, I'm using this, and again, this is certainly a superficial aspect of me describing this, but left brain functioning would be one's conscious awareness. If we had an EEG, this would be beta activity. These are actual waves with a dense cycles per second, right? So beta activity, awaken, alert, left brain. Hopefully everybody is left brain functioning right now. Hopefully if I apply an EEG, we're all in the beta state. We're awake and we're alert. What I refer to as right brain functioning is beyond that. These are the subconscious types of memories that may not be part of our active conscious awareness, but certainly part of our memory system nonetheless. People who might go into an alpha state or theta state, slower waves, may get into this altered state of consciousness where some of these memories just may pop up. Maybe it's because you're just falling asleep. All of a sudden just things pop in your head because you're not actively aware or thinking. That's more right brain functioning, at least in the way I'm describing it. Okay, so that's what I'm getting at. When these two hemispheres are disintegrated, we can actually achieve certain behaviors that are consistent with diagnostic criteria of DID, where left and right brain hemispheres are just not communicating. That is, you've experienced things that you can't remember. And if you actively try to remember, let's say in the context of an H&P, no medications can help this. Any thoughts of alternative therapies that you might consider, the clinician may consider?
You just mean like trauma-focused therapy? CBT?
So trauma-focused therapy is definitely going to be what is prescribed here. And so the patient comes to you and says, hey, I'm here for trauma-focused therapy. Doc, what can you offer me? What are you talking about?
Okay, one second.
Like the type of trauma-focused therapy, you mean, or?
Well, how would that look? I mean, they want to know, I want to sign an informed consent to undergo trauma-focused therapy. What is it you will be doing, Doc?
Talking through.
Yeah, it's talk therapy, and what we would often refer to as working through. In this case, working through prior trauma. And I'd like to meet with you 5 days a week. All right, and we'll take it from there. All right, so that's certainly an option. Any other options? I mean, more specifically, if you want to get to theoretical construct to pin on it, the type of trauma-focused therapy, maybe psychoanalysis, maybe psychodynamic therapy. Probably not DBT. Right? Probably not CBT. Hypnosis. Hypnosis. I talked about the altered state and getting the individual into an alpha state. Well, that's hypnosis. Right? Putting people in an altered state of consciousness so that they can recover those lost memories. Now, it's controversial because we also know that there were false memories that some psychiatrists either intended or inadvertently caused. But there are benefits to this as well. Right? And if under the care of a trained professional, it is certainly a consideration to include into the treatment plan. And I think I may have mentioned this before, but it's probably worth mentioning again. There is a specific form of psychotherapy / hypnotherapy that we should discuss, and that's the video dialogue. The video dialogue. And the video dialogue has a specific focus to reintegrate right and left brain functioning. So somebody presents with left brain functioning, and inasmuch she has provided a full H&P, history and physical, psychiatric evaluation, she's awake and alert, she's talking to me, she's able to tell me the HPI, her past psychiatric history, her current medications and allergies, etc. Beta state, left brain functioning. In the course of this H&P, my patient also discloses a past psychiatric history significant or consistent with DID. And as such, we begin the treatment plan for that actual illness. And we're going to include the video dialogue now as part of the treatment plan. We're going to extend her evaluation to include the video dialogue, and as such, I'm going to put her under hypnosis. I'm going to induce an alpha state. So we're not going to hook you up with the EEG. I know she's going to be in the alpha state because after about a 5-minute exercise, which usually starts out with, what's what I'm looking for? The exercise usually starts out with muscle relaxation, deep breathing, relaxation exercises, and then kind of evolves to guided imagery, which then induces a hypnotic state. And if I did have an EEG, it would show alpha waves. And at this point, I'm going to ask her to be allowed to speak to one of her alters. Okay? And she does, and I will first ask and introduce the alter, inquiring how they would like to be addressed. And they might give me a name such as?
Katie.
Katie. And the clinician at this point will talk directly to Katie and have a normal conversation. How are you? How long have you been here? What do you do? That conversation will all be video recorded. And it goes on for as long as it needs to go on. At the end of which, I will ask my patient to count backwards from 10, stun my fingers, you're going to wake up, refreshed, awake, and alert. Beta state, left brain. After maybe getting a drink of water, relaxing a little bit, I'm going to ask my patient to watch this video. For the first time ever, she is going to be Katie. At the end of which, the conclusion of the video, I'm going to ask her, can you respond? How do you feel? And maybe even get more specific. When Katie said that you were weak, how do you answer to that? What would you say to Katie if you could answer that? Give her a reply. All video recorded. At the end of that dialogue, I will again induce hypnosis and ask Katie to come back out. And Katie, I want you to watch something. Click play. And now Katie gets to see my patient's response directly or directed at her. And I will ask Katie, want to reply to that? This goes on back and forth over weeks. The video dialogue. Left brain talks to right brain. The idea, the fact that these two have not communicated is the core of what causes DID. Now that they're communicating, DID is a chance to resolve. And so that's hypnosis in general, but certainly psychotherapy in general. Hypnosis in particular, in the video dialogue, is a very specific example of hypnosis in addressing the core element of dissociative identity disorder. Unfortunately, our main character in Angel Heart does not undergo the video dialogue, and things don't turn out quite as good for him.
Quick question. What are some successful ways to achieve a hypnotic state?
What are some successful ways of achieving a hypnotic state? You mean self-induced or induced by another therapist?
Like induced by a therapist.
A therapist, I mean, first and foremost, and this is going to seem like a silly answer, but it is true. You should really go to a therapist that's been trained in hypnotherapy.
Right.
I mean, I don't know if there's not a real board certification here, but their background. You go on WebMD, look at my grades. They really should know what they're doing. Unfortunately, I think some folks may claim being proficient when maybe they're not as proficient as some of their colleagues are. Right? That's first and foremost. It actually is formal. It's well, not formal per se, but it's definitely specific training.
I mean, this is being shaded by like culture, but I've heard multiple discussions about the debate whether like DID is actually a real diagnosis or not, or if it's like if it's a real thing, I guess. What is the opinion on that?
Right. I think the opinion is that dissociative identity disorder is a real illness. It is a real mental disorder with a significantly low incidence. And I think there's a couple of things to look at with regard to others that would deem it not real. Number one is pay attention to the co-occurring mental disorders, because sometimes they do include fictitious, and sometimes they do include malingering, and sometimes they do include behaviors that we don't fully understand. And when those co-occurring disorders or behaviors manifest, it's very easy for the clinician then to simply attribute the DID to a falsehood as well. So just be careful of that process. When things are as rare as they are for DID, or as they are in DID, we know that these illnesses are not going to be well studied. But you shouldn't allow lack of evidence to then automatically, as a reflex reaction, lead you to deduce that therefore it's not real. So I think that's a big part of the process here. The other part of the process is that, remember, all of these illnesses, even major depressive disorder, are created artificially. They're created through statistics. And unlike other illnesses that have a germ theory, psychiatry simply does not have that degree of validity. Incredibly highly reliable, but lacking in validity just because of the way these different illnesses are constructed through stats. And when we do that, we have to appreciate that they're really artificial when compared to those with that germ theory. We don't have an MRI to confirm the diagnosis, as many of our colleagues have MRIs, CT scans, and other aspects of laboratory workup, including but not limited to blood work. Psychiatry doesn't have that, none of it. So when we're in that situation, what that usually means is that we try to stick the best we could to the stats, but we also realize that, people may actually come in with something that looks like a variant of what is published, and shouldn't we include that as DID as well, or should we just ignore it and say, I don't know what's wrong with you? And if doctors do that, all of a sudden they begin to go beyond what the statistics are telling us. And if we continue to push that ticket, we are going to find ourselves in a middle zone where others who also don't understand what DID is to point and say, my goodness, it looks like psychiatry found the point prevalence of DID these days to be 55%. Could you believe that? Right? So that's what's going on here too. That's the process behind it. That psychiatry is a statistically based field. And sometimes, and often due to the good of our patient, or for the good of our patient, we don't always stick to the facts because we want to be inclusive with regard to saying, I think this is DID going on. Let's give a variant of it. I think we should treat it the same and see how we do. But once we begin that practice, if you look at a population level, systems level, you can see how the point prevalence going from less than 1% can boom up to 7-8%, and then that gets a lot of people to look at us very suspiciously. And I think that goes on too. Sorry for the long, drawn-out answer, but I really do think those are two main processes that result in many people saying, God, it's not a real thing. Anything else with regard to this character? Related to or in addition to DID?
Is there any thought of maybe some sort of schizophrenia facilitating, staying there in the first place?
Right. So I think, when we look at any character analysis, and we've done this before for other films and for other characters, it really is good practice to begin to look at whether or not we would designate them as being in, let's say, choice or column A in mood anxiety spectrum, or choice or column B, a psychotic dissociative spectrum, and then just continue our case formulation from there. So, that's basically saying the same thing that you just asked, right? And even though, again, because we have these artificial categories, in this case, artificial chapters, schizophrenia and other psychotic disorders versus the dissociative disorders chapters, two distinct chapters in the DSM. The fact is that the way the neurobiology works, they really are significantly overlapped. So while, yes, schizophrenia from the clinician should be in our differential diagnosis, we also have to appreciate the fact that individuals with dissociative disorders do have a very high prevalence of psychotic symptoms. So And whether or not there is a co-occurring diagnosis that meets full criteria that you would include remains to be seen. When met with this dilemma, I think clinicians should focus on the question, if I include a secondary diagnosis, will it alter my treatment plan and help my patient? Because if the answer is no, we have to reconsider whether we want to actually document that or not. Any other characters you want to talk about? We have just a little time left.
You could talk about Louis Cypher, Lucifer. I mean, if we're thinking in terms of outside the fantastical, you could say that delusions of grandiosity, you could say he might have aspects of narcissistic personality disorder. If he believes that he really is Satan, he believes that he really does have control over everything. You could say delusional disorder. He didn't really personally have any psychotic breaks or anything. He wasn't really the one hallucinating. He's the one who, physically saw the murders and stuff. So I would stay in the realm of delusional.
Okay. I do agree with you. Again, I think the way we have to kind of frame this is if Lou presented to you, for whatever reason, and disclosed that he believed he was Satan. I'm not so sure we'd be so quick to say, okay, you got to leave, otherwise, I'll get out the Ouija board and I'll get you out of here one way or the other. I think if you're on call for psychiatry, you're going to address that chief complaint in a very different way than a normal patron would experience it in a movie theater. So when we begin thinking of this character in that context, yeah, I think we would identify that this individual is delusional. And I think that delusional disorder would be a consideration. And I think the way we would get there, again, is to think that, in lieu of him being depressed / anxious, he looks to be psychotic / dissociative. And if that's the case, we have to discuss this maybe as a manifestation of schizophrenia. Just arbitrarily choosing schizophrenia as a place to start. And while he does actually manifest a delusion, right, a fixed belief that he is Satan, that is clinically significant, harm to others, I'm not so sure he has other, as you said, other evidence of psychosis, right, to fill, because he needs two to rule in for schizophrenia. And if that's the case, then what? Well, the answer is that we would go to maybe other illnesses in the schizophrenia and other psychotic disorders chapter. That is, he has an other psychotic disorder. And that one psychotic disorder that is defined through clinically significant delusions is called delusional disorder. Okay? So again, it's not brain surgery. Now, when he's diagnosed with delusional disorder, we have, I think, further evaluation, which is, well, what type? Right? There are several subtypes of delusional disorder. They follow the acronym JPEGs, and they do come up on exams. Right? So try our best to go in order. What are the different subtypes or themes of delusional disorder? J.
Jealousy.
Somebody said it.
Jealousy.
Jealous, right? Do we think that Lou is jealous? So I don't think he has delusional disorder, jealous type. P. Paranoid or persecutory. Right? Does he have delusions of persecution, that somebody is out to get him? This is one, and this is something that's more of a clinical pearl with regard to individuals with some level of insight suffering from psychosis. Whether we call that psychosis, delusional disorder, schizophrenia, it doesn't matter. People with some degree of insight may actually be able to present themselves non-delusional. And the duration of the interview is something that the clinician should pay very close attention to. Because the longer the interview goes on, that's stress. And with increasing stress, the individual may manifest signs of a mental illness, including delusional disorder. So towards the end of the interview, they may actually sound very different. than they sound in the beginning of the interview. And if you notice, the scenes that depict Lou in Angel Heart are relatively short. So I'm wondering if there are things going on that we're not picking up on simply because we just didn't spend enough time with our patient. Right? Because if you know the background to this character, multiple other movies, maybe one of the most highly prolific characters written in literature and movie, Lucifer has pretty significant ideas or delusions of persecution. So it's outside of the context of this particular case study called Angel Heart, but we'll just leave it at that. So it's a consideration. E.
Erotic-romantic.
Good. Erotomanic, the false belief, the fixed and false belief that someone is in love with them. Is Lou demonstrating that in Angel Heart? No. G. Grandiose you mentioned, and I think that is the one here, right? And then finally S, somatic. Somatic delusion. Probably not. So, yeah, it looks like this might be grandiose delusion. Now, there is mixed. So if you really do believe there are delusions of persecution here, and there might be, we would call it mixed type. And then, of course, if they don't meet any specific subclass, they would be undifferentiated, none of the above. For your shelf exam, we probably should review some of the undifferentiated types of delusional disorder. These are usually described by neurologists and usually take the name of the neurologist that first described them. Anybody have any guesses? There's 3 that usually pop up on exams. One is the Capgras, right? Otherwise referred to as Capgras, if you're English speaking. Capgras. What is the Capgras delusion? Or another way to say it, what is delusional disorder undifferentiated type / Capgras syndrome? It's a mouthful.
That's when you believe that people in your family or your life or your pets are replaced by an imposter.
Exactly right. The imposter syndrome, right? The body snatcher syndrome. The delusional belief that a familiar figure has been replaced by an imposter. The body snatcher syndrome. Any movies to solidify this for us?
Freaky Friday.
Coraline?
Freaky Friday, yes.
Coraline?
Coraline. I'm going to say no, and because you caught me. And for that, your sub I now is in jeopardy. Because that's a 4th example. I said 3 examples common. Here's a 4th example. Thank you very much for that. We're going to get to that in a second. Anybody else other than Freaky Friday? It's a good one.
Cinderella?
Cinderella.
I'm cheating because these are movies we talked about last year in other contexts, but I think I remember like briefly discussing this aspect.
You were part of Cinderella.
Well, like evil stepmother, evil stepsibling.
Oh, yeah.
Could be.
Right. Let's not go there.
Okay.
That's too much of a tangent. I don't want to go into that tangent universe. That'll take us down a rabbit hole nobody wants to. Well, I would love to go down, but we just don't have the time to go down right now. That'll be a different podcast.
I think potentially our next movie, The Skeleton Key, could kind of make the argument for it.
That's right. Skeleton Key. Good. Yep. Good. All right. The delusional belief that a person or a place exists simultaneously somewhere else, Coraline, is called reduplicative paramnesia. Reduplicative paramnesia, right, which is a form of undifferentiated delusional disorder. Right. Basically, it's the entire Lovecraft genre. Again, too much of a tangent today, too big of a rabbit hole to go down. Number 3. Any other examples of undifferentiated delusional disorder?
The belief that you were dead.
Good.
I don't remember what
Cotard
it's called.
syndrome.
Yeah.
Right? The Cotard syndrome. COTARD. the delusional belief that you or some aspect of yourself is dying or dead. Doc, I don't have a heart. My heart's eroding. I can feel it. It's actually rotting. Doc, I don't have a brain.
Could that be a more extreme version of somatic delusion?
Somatic delusion, on the other hand, focuses on 3 subtypes or examples. Number 1 would be infestation, so it doesn't really fit infestation.
Okay.
Another one is, trying to get to 3 now.
Is it believing you're pregnant?
Suicidal.
Is that one of the
So
somatic?
that
or is
might be,
separate?
that might be, I think it's called dysmorphophobia, maybe. Which might be as example as a quote unquote hysterical pregnancy, or formerly named hysterical pregnancy, quote unquote. And there's a third called halitosis, the delusional belief that you're giving off an odor. All right, so probably not a form of somatic delusion. By the way, with film, in which a character, after sustaining a traumatic head injury, becomes psychotic, specifically of the Cotard delusion, that she is without a heart or a brain, or courage for that matter.
Wizard of Oz.
Wizard of Oz, good. And the fourth and final is the delusional belief that an individual can actually, what is referred to as, enter into intermetamorphosis. Right? The shift, no, spelled it wrong. Shift shaping syndrome. That's the Fragoli syndrome, otherwise known as the shift-shifter or shift-shaping syndrome, Fragoli. What movie?
Teen Titans?
Teen Titans may be correct. I have to be honest, I have never watched them.
You got it.
My loss. The Matrix. The Matrix. Mr. Anderson, who is demonstrating aspects of the schizoid personality, personality disorder we know poses risk for developing a future psychotic disorder as a result of an undue stressor, has a psychotic break that includes the Fragoli syndrome.
So, one day when I was doing...
Anything else with Lucifer? The other thing I just want to briefly mention on Lucifer is that it gets into the nature versus nurture discussion of what is either predisposing or perhaps even precipitating, maybe even perpetuating his illness called delusional disorder. And even though the delusion doesn't necessarily link to this per se, but he has aspects of the antisocial personality. I mean, it's hard to say that the devil doesn't have a blatant disregard for others' rights or safety. He's the embodiment of that, or it is the embodiment of that. That said, genetically, I think the biological factors that are part of the biopsychosocial discussion of what causes this are relevant here. I mean, there's no better depiction of the embodiment of evil than Lucifer. So it gets into a nice discussion of not only the biological factors that are contributing, in this case really more to the antisocial traits, but if you look at bio versus psychosocial, nature versus nurture, therein lies your nature versus nurture discussion of what ails Lucifer. Of course, the clinical parallel to this are these serial rapists and serial killers that when they meet with a psychiatrist and they undergo psychiatric evaluation upon being apprehended, have no developmental history that would suggest such heinous crimes. Okay, now Manson, Kempfer, they had significant histories, but some don't. Clifford Olson. So every time we see a case like Clifford Olson's, we stop, pause, and think, is there such thing as a bad seed? Right? So, a little bit of a tangent, but I think Lucifer, I mean, there's no better character than Lucifer that would embody that very discussion. Right? Nature versus nurture, bio versus psychosocial. What if we looked at Lucifer's history being devoid of any psychosocial factors that would explain his current behavior, leads us to that very question. Is this all biologically predetermined? Of course, is there such thing as a bad seed? Just another way to ask that question. By the way, and I'll end with this. Well, two things. One, a character that we didn't talk about. I'm blanking on her name.
Epiphany?
I'm sorry?
Epiphany?
Epiphany?
Is that his daughter?
The daughter, yeah.
Yeah.
So, I mean, I think for certainly purposes of having Angel Heart serve as a case analysis, I believe she is perhaps and arguably the most important character in this film because of the different behaviors we see her engage in. So we see her engage in very ritualistic behaviors, and inasmuch we come to believe and we come to know that this movie called Angel Heart is about voodoo. That contrasts to our Night's Watch movie today, which is about hoodoo with an H. And we'll discuss what that is in about an hour. But voodoo is a religion. And it's a religion that we believe began in Haiti as a result of the emergence of both the Christianity of the French who were occupying Haiti at the time and African animism, the combination of which was called voodoo. And while I really am with about zero knowledge about the practice itself, it's certainly in layman's terms, one part of the ritual is through singing and dance, the individual enters into a state of trance with the idea that their soul leaves their body. It goes someplace else to become enriched and then returns so that they have a higher state of awareness. It's an enriching ritual. And the question then comes, or could be posed, soul leaves one's body perhaps during such a ritual, but never returns. The result, of course, then would be, for lack of a better description, a soulless body. What did the Haitians call that?
Zombie?
That is the derivation of the zombie. The zombie has its roots in Haiti, not the U.S. It doesn't make the U.S. until about truly 1952 or so. Right? So that might be what's going on here. And I found that interesting because this movie stays a horror movie, a psychological thriller horror movie. But the genre of horror will switch. We think that it's a supernatural horror film. I mean, it's got Lucifer as one of its main characters, right? Maybe not. Might be a zombie movie. Right. Now, the background here, too, is that zombies were created sometimes to silence political dissidents. So individuals would have the ovary of the blowfish blown in their face, otherwise referred to as zombie dust. By the way, the poison that takes effect is called what? In that circumstance, from the ovary of the blowfish?
The secret toxin?
Right? They will actually become breathless. They will have a heart rate that will be undetectable. They will be put into a shallow grave. And then when the poison wears off, they arise from the grave. And anybody who witnesses this, of course, would typecast them as a zombie. It was a way for the government to dispense of their political dissidents. So the question then becomes, what does this particular character in Angel Heart know that might have somebody want to typecast her as a zombie? And does that answer actually change the plot of this entire movie? Because it's something that we probably haven't considered, and therefore something that we missed this whole time. Okay, so we'll leave it there. It's more of a thought-provoking idea in terms of the plot and which way the plot would therefore unfold. What did this character do? What does she know? Who does she have one on? That will result then parallel to another government disposing of her the way she is. All right, so we'll stop here. All right, we'll break. We'll resume back.